नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about Megaloblastic Anemia. In the last lecture, we have discussed about anemia classification and iron deficiency anemia. In today's lecture, we are going to discuss about megaloblastic anemia. Deficiency of vitamin B12 or folic acid or from disturbances in the folic acid metabolism leads to the development of megaloblastic anemia. Vitamin B12 deficiency, but not the folate deficiency, is associated with neurological diseases in up to 40% of the cases. The causes of megaloblastic anemia can be broadly divided into two categories: vitamin B12 deficiency, and number two is the folic acid deficiency. In vitamin B12 deficiency, there is inadequate intake, that is a strict vegan diet or the poor quality of diet. And the second one is the malabsorption. Malabsorption from the gastric or small intestine, gastric, that is pernicious anemia, congenital intrinsic factor deficiency, and gastrectomy. In the small intestine, there is bacterial overgrowth with the Crohn's disease, tropical sprue, and severe pancreatic disease or the drugs. Now we come to the folic acid deficiency. Folic acid deficiency results due to the inadequate intake, especially in the infancy, old age, poverty, and alcoholism, etc. Second one is the malabsorption. Malabsorption is celiac disease, tropical sprue, dermatitis herpetiformis. There is increased utilization or loss. It can occur in the physiological or the pathological condition. In physiological conditions like pregnancy and lactation. In the pathological conditions like blood disorders, malignancy, dialysis, and severe inflammatory diseases. Antifoliate drugs includes methotrexate, anticonvulsant drugs, etc. The clinical features includes the symptoms like malaise in 90% of the cases, breathlessness in 50% of the cases, paresthesias that occur in 80% of the cases, sore mouth that occur in 20% of the cases, weight loss, altered skin pigmentation, gray hair, and impotence. I will again repeat the clinical features, the symptoms of megaloblastic anemia, which includes malaise, breathlessness, paresthesias, sore mouth, weight loss, altered skin pigmentation, gray hair, and impotence. The other clinical features includes poor memory, depression, personality changes, various kind of hallucinations, and visual disturbances. Poor memory, depression, personality changes, hallucinations, and visual disturbances. The signs of megaloblastic anemia includes the smooth tongue, ankylosing, vitiligo, skin pigmentation, heart failure, and pyrexia. I will again repeat it: smooth tongue, ankylosing, vitiligo, skin pigmentation, heart failure, and pyrexia. The other clinical features includes neurological conditions like vitamin B12 neuropathies due to symmetrical damage to peripheral nerves. Legs are more affected than arms. There are various neural tube defects like folic acid deficiencies during pregnancy that causes spina bifida, encephalocele, and encephalopathy. There are various gonadal dysfunctions like deficiency of vitamin B12 or folic acid that causes sterility, which is reversible. Next, we have epithelial changes like glossitis, and in CVS there is raised serum homocysteine concentration that is associated with arterial obstruction and venous thrombosis. The investigations that could be done in case of megaloblastic anemia includes the hemoglobin level that is reduced, MCV is greater than 120 femtoliter. The lactate dehydrogenase is raised with serum ferritin is elevated. In the blood film, there is macrocytosis that is commonly seen. In the bone marrow examination, it is differentiate B12 malignancies, folate deficiencies from non-megaloblastic causes such as alcohol and liver diseases. Serum B12 and folate assays can be done. In vitamin B12 deficiency, it is less than 110 nanogram per liter. So we have hemoglobin, MCV, LDH, serum ferritin, blood film, bone marrow examination, and serum B12 and folate assays. Now we come to the management of megaloblastic anemia. In the management, the treatment always includes both the folic acid and vitamin B12. Vitamin B12 deficiency is treated with hydroxycobalamin, 1000 microgram IM in 5 doses of 2 to 3 days apart. That is followed by a maintenance therapy of 1000 microgram every 3 months of life for life. Oral folic acid of 5 mg daily for 3 weeks will treat the acute deficiency, and 5 mg once a weekly is adequately maintenance therapy. Now we come to pernicious anemia. Pernicious anemia is an autoimmune disorder in which the gastric mucosa is atrophic with loss of parietal cells causing intrinsic factor deficiency. So there is intrinsic factor deficiency in this case. In the absence of intrinsic factor, less than 1% of dietary vitamin B12 is absorbed. The age of onset is 40 to 60 years of age. 6. It is more common in females and there is a strong family history association. It is more common in individuals with other autoimmune disease like Hashimoto thyroiditis, Graves' disease, vitiligo, hypoparathyroidism, or Addison's disease. The diagnosis of pernicious anemia. The findings of anti-intrinsic factor antibodies in the cortex of vitamin B12 deficiency is a diagnostic of pernicious anemia. Antiparietal cell antibodies are present in over 90% of the cases, but are also present in 20% of the normal females over the age of 60 years. Patients with low B12 levels and negative anti-intrinsic factor antibodies should have a Schilling test performed. So Schilling test is important. Now what is done in the Schilling test? Radio-labeled B12 is given orally plus 1 mg of ordinary B12 is given intramuscularly. It blocks the transcobalamin binding sites and ensures that radio-labeled B12 is absorbed from the gut and directly be excreted by the kidney. Now, the cobalt-58 is excreted in urine over 24 hours. If it is less than 10%, then proceed to part 2. If it is greater than 10%, then there is normal B12 absorption. If the excretion is less than 10%, then again give radio-labeled B12 as above and 1 mg ordinary B12 intramuscularly, plus also prescribe certain intrinsic factor. Now, if cobalt-58 is excreted as above, it is less than 10%, then there is gut disease. And if it is greater than 10% after administration of intrinsic factor, then it confirms the presence of pernicious anemia. Now the treatment of pernicious anemia. The treatment can be divided into 2 broad categories, due to vitamin B12 deficiency and due to folate deficiency. If it is due to vitamin B12 deficiency, then hydroxycobalamin 1000 microgram IM in 5 doses over 2 to 3 days apart, and it is followed by a maintenance therapy of 1000 microgram every 3 months for life. A sensory neuropathy may take 6 to 12 months to correct. In case of folate deficiency, Oral folic acid 5 mg daily for 3 weeks will treat acute deficiency, and 5 mg once a week weekly is adequately maintenance therapy. So it was all about today's topic. In the next lecture, we are going to discuss about hemolytic anemia. This session is powered by digital version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any issue, kindly mention in the comment box and try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.